in all of LA.
Oh,
Dr. Steph has known her for longer than I have. I've known you like
correct. We've been
15,
friends
16 years.
Yeah,
I have
we've been
heard
friends
your name.
for 25 years, Seth and I.
Yeah.
We did our master's and doctorate together,
Wow.
and our internship together. We are really good friends.
Probably like 10, 20,
10, 20.
if that's okay.
Okay, so I'll go very fast. Just
Because we've got
really-
new clients coming in. But I do want to bookmark this because Laura, this would be a great referral for Esther. Because if she goes to Spiro, they're in the Palisades.
Yes, there are enough.
And so it's just a beautiful, conscientious handoff, and we've worked together on cases, and I've been to her programs, and clients just love working with her team. So that's why this is important, because if I come back and you don't meet the people, it's not the same as when people come in and you get to connect and feel their energy.
Yeah, so that's why I came in person to just briefly introduce myself. But Reconnect is an integrated trauma treatment, so that is our main specialty, and it is integrated because we do neurofeedback, acupuncture, mindfulness, EMDR, different somatic therapies, movement therapies, art therapy. We have a psychiatrist, and so we have a PHP and an IOP program.
What's the name of it again?
Reconnect Integrative Trauma Treatment. I actually have business cards, so I was just gonna pass them around if you want. So what's really different about us is that we do much more individual therapy than group therapy. So in our PHP program, out of 25 hours, they actually get 22 hours of individual sessions and 3 hours of group.
Which
and the reason of that is because we believe that the group therapies work better for different type of topics like addiction and support, but we do a lot more trauma processing and trauma stabilization, and we find that they are more emotional focused, so that's why we do a lot more individual therapy with them. So it's highly individualized. When a client comes and they get their assessment done, we put together a program, and every week our clinical director meets with them and go, so how's your program going? Whatever is not working, we switch and adjust until we have the right formula for each client. And we alternately meet with every client, so I'm very hands-on. And then of course we have staff meeting like you guys do, and we do trauma trainings on an ongoing basis on site, and so that's what we're very focused on. But I wanted to briefly talk about this topic because the main reason is I'm getting a lot of clients coming from different treatment centers or different therapists, and they are telling me horror stories about their past therapeutic trauma experiences. So not only of course they have their childhood traumas, right? But they talk about how in treatment they get re-traumatized. So I have had so many horror stories that I started getting between angry and passionate about really wanting to educate people of like, please do not do these type of things. So what I decided now I'm doing is I'm going around meeting different treatment centers and giving some case examples of how we used to think of trauma treatment being good and actually how damaging that could be. So that's the reason why I'm passionate about this topic. So I have some slides I want to look at it to make sure. So in general, I want to say that my philosophy in working with trauma, and that's it's ingrained in Reconnect, that's what everyone knows, is that we work very slowly. We focus on stabilization, grounding, and resourcing as an initial phase. And that initial phase is really supported by various modalities. So acupuncture is there to calm the nervous system down. The neurofeedback is doing the same thing. Somatic experiencing is used to calm the nervous system down. So we do CRM, comprehensive resource model. It has a lot of different techniques of breathing techniques and visualizations. And so we spend a lot of time in the beginning to make sure that the client, as I call it, the immune system, gets strengthened. Until that's done, we do not jump into trauma work. I say that because clients, when they first call, they're terrified. Oh gosh, I have to work on my trauma, that's what my team is saying, I really don't want to. We tell them trauma work doesn't necessarily mean that you have to open up stuff right away. In fact, sometimes you never have to open the memories. It's all about really just being able to deal with it and tolerating. So we work a lot on increasing their emotional capacity. And we educate them a lot with that. So it has to be slow. I don't believe in cathartic, huge experiences where some people think that's what's necessary for trauma treatment to happen. So we tell them about that, and they seem to really relax.
Quick question.
Yeah.
sometimes you get the clients that come into treatment that feel like by doing the more benign modalities and doing the self-esteem building first, that they're like, I came here to address my trauma and we never talked about it.
Correct.
So how do you?
We had the exact same fight yesterday with a parent, in fact. So I gave this analogy and they understood me. I said this decision of when to go into the processing has to come from a clinician and not from a client. I said, imagine your daughter, because it was a mother, has cancer, and she goes to the doctor and says, I'm ready for radiation. And the doctor treats her and says, well, not yet. I need to give you vitamins for about 2 weeks, and we need to do these shots for 2 weeks, and then I'm going to start the radiation. Is your daughter going to fight? No. If the radiation is not happening today, I'm going to another doctor, or is she going to listen to the doctor? I said, we are in that situation. This has to be done in a gentle, slow way, and sometimes clients will fight us, and we'll continue to educate them. And if they do and they leave, in a way there's not much to do. But starting on time is an art, because sometimes I find the problem also happens in the other side, where therapists never touch the trauma, so they're terrified. So then the clients go, okay, they never touched it, where the client is actively having PTSD symptoms like already nightmare and flashbacks. They're already thinking about what happened all day. So you should dare, but how to dare, right? That's the artwork that I feel we're good at, and we continuously educate clients about it. But yeah, it's something that happens. Another important part of my philosophy about trauma treatment is that definitely has to be body-based and integrated. So when they just do EMDR, I think something is missing. When we do EMDR, follow up with a somatic session, they're processing the memories, they're working through the body, and then they go into acupuncture. That whole is everything really is a piece of the puzzle, and it just comes together in a very very integrative and cohesive way. Let me see. Okay, so a couple of common mistakes and beliefs that I'm hearing over and over again. Am I done? No.
It's just my affirmation reminder.
Oh, nice. Okay, that you do with
my
clients.
affirmation reminder.
So one common mistake, and sometimes therapists don't make these mistakes, but clients know these as normal, it should be, is that they think they have to tell their story. Or they have to tell their story over and over again. Those are the common two things. So it's not important anymore. So again, we do a lot of psychoeducation about that. Another common mistake is skipping or minimizing the stabilization phase. I know clients who come from different treatment centers that tell me day one they jumped into the trauma, right? That's the flip side of what you are saying. Pushing for traumatic memory processing. So trauma work also can be done without even ever touching a trauma memory. I have done that before, where the client got so stabilized. Are the memories still there? Yes. But she was functioning. She didn't necessarily need to be processing the memory. So it really depends on the goal, on the functionality of the client. And so sometimes you can really skip that if you find that the client is able to tolerate it. So every action is necessary. That's another common mistake that people think. Unless you're crying and, I don't know, hyperventilating and having all these emotions that you're not really processing. So the clients tell me, but I didn't cry. Good, you don't have to cry. So that's another common mistake. And then the last one I have in my list of 5 is that doing memory processing during group therapy. Our philosophy is that group therapies are much better for support, education, skill-based. But the moment you go into detail of, especially like sexual abuse stories or more detailed like this, and then the clients are sharing those, you have a risk of a re-triggering, re-traumatization of a client. Recently we had a client who, after treating her for 2-3 weeks, we realized she had eating disorder, and we said, okay, that got too active now, we're going to have to pause the trauma treatment for a while, go to ED, then you're welcome to come back, which we often do stuff like that. But the same thing would be if they relapse on drugs, you have to go detox and come back. So we sent her to ED facility. She came back running, saying one of the groups they did was one of the girls was talking about the details of her rape. And she all of a sudden remembered details of her rape that she didn't remember to this level. If you have a client remembering such detail in an uncontained environment next to other people, she doesn't even have the preparation nor expectation, you can even have really psychotic breaks. Some people go all the way to suicide. So it's so fragile, and what I'm seeing is that people don't realize how fragile this topic is, unfortunately. I have a couple of other case examples that I would like to give you. I'll stop for a second and see if any question or comment you have already.
That's very helpful, thank you.
Oh, yeah, spot on. I guess the one question would be how, in assessments, assessing the client, that's a slippery slope, bringing people in,
Okay.
because you kind of want to know how to unpack it.
Right.
Do you have any guidance?
I do.
on
In
that?
fact, my first case example was that.
Okay.
So I had a client who had eating disorder, drug abuse, trauma history, everything. She's been in treatment for 3 years. Finally, she was doing a little better, and she was suicidal in the past. So after doing a little better, they said, you know what, now you have to do more trauma work. So they sent her somewhere with an in-network. She didn't have the money to come to us. And first day, the intake was 2 hours. 2 hours with gruesome details of asking every single detail of her abuse. And this is a woman who was sexually abused by her father. And some details she didn't even dare to say in the 10 years of therapy that she's had. She wasn't prepared to publish them. At the end of the 2 hours, she said her flashbacks came so strongly that 3 days later she ended up in the hospital psychiatric unit on hold for suicidal ideation for 10 days. And I mean, so there is intake and there's intake. So if you do intake in this detail, you can, like I said, you can create such a horrible reaction. So the way we do intake is actually, we do not get details. We ask a really umbrella question of, in the initial one, right? Do you have a history of abuse? Yes. In fact, I tell client, please don't tell me what it is. I do not want to know, and that's because of for your well-being, because it could be really dysregulating for you or very upsetting for you. So please just give me the headlines when I ask you. Physical abuse, sexual abuse, yes, yes, yes. So I get some symptoms and everything. This is just the baby assessment. When we get into more of a history, real history, taking kind of what you're saying, that's not done with our intake department, but it's done with our clinical clinicians. So, and that's sort of gradually asking and really, you know, checking in. But sometimes another thing I do is, if a client has already been to another treatment center and they have done a huge social biopsychos, I read that and I go, you know what, I have already a lot of your information. You don't need to repeat it. I'm trying to avoid them to tell me the story over and over again. So again, you have the flip side. You have clients who go, I really want to tell you, and they're just telling me all the details, and I'm seeing them getting dysregulated right before my eyes. So I let them, I basically say, I'm sorry, I don't mean to be rude, but I'm going to have to pause right here, and I educate them about why it's not good to talk about everything all at once. And they get it, and they actually, it happened even yesterday on the phone with someone who was just calling me, and she said, oh, thank you, I didn't realize I was getting very upset. Like, they need my containment. I'm not going to leave it up to them to contain themselves. So, a lot of other bad examples I had is unfortunately with EMDR. I love EMDR. I am EMDR trained and I've been using it for about 17 years, extensively and intensively. But some of my colleagues use EMDR without resourcing the client enough. And so when I say EMDR to clients, you know this, many of our clients are scared. Oh gosh, no way, I'm not doing EMDR. And I tell them, let me do the way that I do. And then you tell me how you're experiencing. So my goal is for them to gradually open. Sometimes I do literally 2 minutes. I'm not kidding. 2 minutes of an EMDR or 2 minutes of touching the trauma, maybe just this much. And then I take my foot off. And I go, how do you feel? Okay, we pause right here. But we didn't process anything. For today, that's what we're going to do. Let me know how your day goes. Tomorrow when you come in, I'll do 3 more minutes. So gradually increasing it, depending on the client. But it's better to be cautious than opening too much. But again, it's artwork. If you don't open anything, then they're staying with this level of, it's art. You have to play with it.
Super practical question, just because we do have a client that will be transitioning probably soon. Would you recommend PHP initially and then going down to IOP, or does it vary per client?
It does depend on the client. I do like most of the time from a residential going down to PHP, but there are some clients that can tolerate going to IOP if they have enough stabilization.
So The complexity is you could have, you could get a patient from us that has multiple concussions, bipolar 1, PTSD, severe, and some lingering going on. Okay, personality stuff. So you have you've got 4 different modalities going on to whack-a-mole, whatever's coming up in the moment, and that isn't art, not a science, right?
Right.
It's like, that can all happen in 3 seconds, over and over.
Yes.
They're shifting into, whatever's going on. And I think the complexity sometimes is with the personality piece.
Sure.
The pervasive personality, whether it's histrionic or borderline, maybe some splitting, but yet there's obviously it's all driven by the PTSD.
Right.
So how do you deal with the personality aspects of it? Because which would require a more black and white approach. If you went to creative care, it would be all black and white. Do you want chocolate or vanilla?
Right.
Neutral, pithy, not
Right.
creative care, Clearview. They
right.
deal with borderlines, right?
Correct, yes.
So they're the experts in that.
DBT, yeah.
But I think what happens is Milestones is more, and we're all getting the same clients, but for sure we're getting like the trifecta of diagnostics. So how do you deal with like that piece of it where it requires more of a direct approach?
Right. Well, we have
versus-
both in our, for instance, with people who are dealing with drug and alcohol addiction, we have people who are specialized in addiction. So in addition to the whole trauma treatment, once a week or twice a week, they are seeing our specialist. So there's constant support about that. If they have eating disorder, but not too active where they need ED facility, we have ED specialists. So they meet with the ED specialist, including a dietitian. So it really is, we are trying to target from every angle. So, and if we think the client cannot tolerate, again, trauma work, we just stay in the stabilization for a longer period
Do
of
skill
time.
building.
We have the DBT, we have the resourcing, and so that's why I said we just,
You would, so
Cool.
you have a tendency to pause the trauma work and just
For
say,
sure.
let's go straight into skill building and talk,
Correct.
so you can tolerate all of this, and then we can move back into
yes,
the
but
trauma.
our skill
Do you
building,
explain that to them?
we do, our skill building has also, it's not just cognitive oriented therapy, but we do skill building a lot with the body. Because we do so much, they get 4 hours of somatic therapy a week, plus acupuncture twice a week, plus neurofeedback 4 hours a week, plus the movement therapy. So those are all things that really calm the body down in order to tolerate. So because I think DBT is great, but it only addresses the head, so it's just top to bottom. We're doing a lot of bottom to top, so there's really a better a mixture of things. I believe in CBT, I believe in DBT, but when it's just used as the only source to a client who's so traumatized, it's really missing the other piece.
Yeah.
So we are not missing that piece, we're just putting much more emphasis on emotional focus and body-based therapies.
To the client I think you're speaking of, I've noticed that by going in with heart rate variability training first, he was able to see the hiccups in his heart rhythm. And so not only did it ground him to the moment, but he was able to recognize that this self-regulation can happen on a screen, and that feedback
Right.
got him excited about it. It actually gave rewards, it's a reward system
Yes,
to
I can-
wanting more
I can
stabilization.
contain myself.
Yeah. And he really enjoyed seeing him go from this hiccup in his heart rhythm to a perfect sinuous wave. And it's so funny you're saying that, because that was my intuition with him, to go in through. Would you recommend, like, when in doubt, heart rate variability is the safest way to, providing, as an ancillary therapist here,
Right.
to
Like a hard math, for
yeah, hard
instance?
math,
I
yeah.
know, yes, I have a colleague who does that.
yeah, heart rate,
Yeah.
just to go into self-regulation, regulatory
Yes,
capacity, just to
definitely.
build it, and then trigger little triggers, 1 to 10, 1 or 2 triggers, and they see themselves get dysregulated and
Right.
come back, and then
Correct.
they build the
It's also about-
resilience.
yeah.
Right.
So when we work with trauma, for instance, we first instill lots of these resources, let's say the breathing techniques and this, and then we go, okay, hold this. And when you bring up a trauma memory, what happens? But we're not doing 5 days resourcing and then 5 days. There's a fluidity constantly. So you are doing the resourcing while you're bringing the trauma memory. You are remembering the resources. Like when I do EMDR, for instance, let's say I find that the clients are going really out of the window of tolerance of how much they can tolerate feelings, right? Go, let's pause right here. See, in the old EMDR, it was like, push it through, push it through. What is this? It's just like it really revels the clients up, and they just can't tolerate. So I go, let's stop. okay, let's remember the breathing technique that we did the other day, or what's your power animal? There are some techniques that we teach. Oh, okay, or who's your support system? When I'm thinking of my dog, when you think of your dog, feel your dog in your body. Now when you think of the trauma, what happens? So you're never leaving the body, you're never leaving the resources, you're not just going, okay, tell me what the memory is about, and you push it through, like I call it Nazi approach a little bit. So does that make sense? That's the fluidity of it. It's like constantly you're coming back and forth to the resourcing. So in fact, let me see here.
And that fluidity is the personalization of the program, because everybody's system is very different. So the tools are very similar, but how you use them on each individual client looks very different.
How many patients do you have at any given time, generally?
15 to 20 intensive program, and then we have a lot of like clients who come in less than 9 hours a week, where we call them just outpatient. So,
That's a lot.
yeah, it's a lot. So some of the reactions that happens if your treatment is not going well is the client is dissociating more, right in front of you, or after session. I always ask the client, after we were done, how was the next 24 hours? Gosh, when I was driving home, I got lost. Okay, that's a sign of dissociation. So something was too much. That's what I go back, and then we have to dial back. You know,
I like that you're constantly assessing,
yes,
pulling in and putting on the gas and pulling it off.
yes. There's constant break
And
gas,
asking
break,
them.
gas. So sometimes their symptoms get worse, flashbacks and nightmares, and sometimes they think, oh, that's good. Well, not necessarily. Sometimes it could be good. Sometimes it's really processing. But there's a lot of detail to ask about that too. When they have nightmares, for instance, I ask, is it the same nightmare all the time? And after our sessions, did the nightmares change? No, I'm still having nightmares, but I asked the detail of the nightmare. Actually, I realized in the last nightmare, I was fighting back my perpetrator. Oh, that changed. That is not that much of a nightmare anymore. You process and you gain something. Or they realize they're remembering different memories in nightmares. If it's not looping, the client is in the right path. If it's looping, something is not going well. So a lot of PTSD details I check in at every session to get really this feedback from them to understand if my treatment is going well or not.
Have you ever considered doing a blog? I think this problem that she's saying is so, unfortunately, so common. I mean, we just had a friend who shared a story, actually just yesterday. It was someone I've known for a long time, and they had a breakup, and they went to a psychologist in Orange County, was just pushing old trauma work. And she said, no, I've got that under control. I just need practical boundaries. I can't sleep at night. Just give me some skills and some boundaries. And so she had to fire that psychologist.
Yeah, I don't blame her.
And then went to another therapist and had a complete opposite.
Yeah.
And came out empowered and feeling like I'm heard, I'm validated, I have tools, I'm doing assignments, I'm journaling, I'm back to skill building.
And you know what
really
happens, unfortunately, most people don't fire their therapist.
They
They go,
stay.
something is wrong with me, my therapist says I'm not progressing, or I'm not treatable, my trauma is not treatable. These are like, it's so shame-based. And or they think, I'm supposed to overcome my trauma with my head, because it's all about willpower and your cognitive capacity. Yeah, so when we educate, no, that you can't just overcome trauma just because you decided. They go, oh, thank God. It's not because something's wrong with me. I have PTSD. I am thinking of creating a blog.
Yeah, because you could post those to,
Yes.
fellow colleagues or to clients. Just say, okay, this is just a blog,
Well, but that's also why I said in the
information.
beginning I'm very passionate that not, if you have other places that you think I should go and speak, because I'm really because I really am very passionate, because I see so many mistakes in the trauma treatment that it really breaks my heart. Because it's something where we're supposed to help, and we end up with hurting the clients, and that there's not enough education. In fact, I'm going to pass this as well, since I don't have enough maybe, but do you know Babette Rothschild? She's a trauma, very, very well-known trauma therapist and a lecturer. She wrote the book, The Body Remembers. So she and I are doing a workshop for 2 days about how to do safe trauma treatment. So this is sort of like an appetizer. If you want much more information about really doing good containment, it's a Friday and a Saturday, 13 CEUs. and you have the information
Beautiful.
there.
Beautiful.
Yeah.
And they have the Trauma Toolbox podcast with all the best trauma therapists
yeah.
in the country. You should be interviewed on there too.
Oh,
So you can listen to that podcast and you can.
Trauma Toolbox, is that what it's
Trauma,
called?
I'll send you the link.
Okay.
Yeah, that's where I go for them.
Thank you. Oh yeah, that's right. Okay, it's 10:23.
Oh, okay.
So I have much more to talk, but
Well, and so the workshop's gonna be where?
West LA Olympic Collection.
Okay.
If you have other colleagues,
Yeah.
please pass this around. The reason why I'm so also really want to promote Babette because I'm sponsoring her is because I want to continue to study with her. I've been following her for 15 years, and she had moved to Europe and she came back finally. She's an amazing person, and she really is gonna teach a lot of great skills, very easy tools. You don't have to be licensed therapist. But any your counselors, your RAs, or whoever, if you want
Yeah.
basic trauma knowledge, they'll get this in this 2-day workshop. And then, if we have enough people this time, then we'll continue more
Yeah, we could go
advanced.
sponsor one out here too.
Okay.
We've got 3 things coming up, up until January, but after that, we'd be free to co-sponsor and put it out there for
Great.
people. And then WAT too, you should speak at WAT.
Yes, lots.
Because it's information, it's good to have these conversations. Have you worked together before?
No.
Okay, summer's
There's no
been in the
time.
field
It's
for a
9
while.
a.m. to 5 p.m. day, 2 days.
2 days.
Yeah. If you go on the line, I think we'll have more information there. And then she and I, so I'm speaking there for just an hour. The rest is really her. I'm just joining her basically. But after that, we're gonna do other workshops together. So I'm very excited about
job.
it. Yeah.
Thank
Thank
you.
you. Thank you.
Important topic.
So, yes, it is really, really important topic. So I hope you'll come to the workshop because you'll find it very helpful. And if not, just definitely read her book if you haven't read so. It's very good case examples there too.
And the other thing is in the dual diagnosis is if you trigger them too much, and they're gonna want to quell that anxiety and self-medicate in some way. So
Yeah.
you can have AMAs, prevent AMAs through all of this good training too.
Yes, actually, can I read just one sentence before?
Oh, sure.
Okay, so I pretended like I'm a client that I don't know anything, and I went online and I said, I wonder what I'll find about trauma treatment. So this is what I found about exposure therapy, okay? Early on in treatment, your therapist will teach you breathing techniques to ease your anxiety when you think about what happened. Okay, this is good. Later, you'll make a list of the things you've been avoiding and learn how to face them one by one. In another session, you'll recount a traumatic experience to your therapist, then go home and listen to a recording of yourself. Doing this as homework over time may help ease your symptoms. Could you imagine as a
Turn you
rape
into a
victim?
hardcore drug
I
addict.
feel like I try
That's
to
the
like
solution.
almost look at it from like an OCD perspective, like keep exposing yourself to it and you'll just tolerate it. But trauma's not the same thing as anxiety from
That's
OCD.
what, could you imagine being as a rape victim and, oh, let me tell them about my rape story, and then you go home and listen again and again. Yes, I mean, I say that because exposure therapy is still used for trauma. Please do anything but exposure for trauma. For other things it works. And VA is still using them. Clients are dropping like bees, dead bees. I mean, it's awful.
It is.
So I just wanted to share that's what's
I was-
out there.
Back in the Midwest, we were scolded so bad. 30 years ago, the first word that my mentor and LCSW facilitator taught us is to put therapist on the board and then put a slash between the E and the R. The
The rapist.
rapist.
Oh my God.
And that was the first thing I was taught. I'm like, oh, you know, it's so true. If people don't know what they're doing, and
You can do a lot of
good
damage.
supervision for interns, right? For
Yeah.
everybody.
Yeah.
There's still questions 30 years later. It's just like
Yeah, well,
more and
because
more
this
comes
is
up.
evolving all the
Exactly.
time. You know?
Who else do you recommend to follow? Who do you think is state of the art and best at trauma? Besides you two. And your clinical
Definitely sensory motor and somatic experiencing. So Peter Levine and Pat Ogden. Those two techniques are my favorite. It's because it's gentler, slower, titrating it, and it's again somatic, and they don't overly work on it.
And Parnell, what do you think of Parnell?
Laurel Parnell, I have mixed feelings
Okay.
about it because she's all her trainings when she does EMDR, she does with closed eyes, and I don't ever recommend doing trauma memory work with closed eyes. It dissociates the clients, and she's not even using eye movements in EMDR, which is how EMDR was founded. She's only doing this, you know, the sound thing that they have
Yeah.
the beep, and then with closed eyes, it's very hypnotic almost. So For trauma treatment, that could be very dissociative. I'm sorry, by the way, I don't mean to offend anyone if you are doing that, so this is my personal experience, you know?
No, that's why I started going to heart rate variability first, because if they go into hypnosis right away, they'll dissociate right from the
Yes.
trauma and they'll spin around somewhere else.
Right.
So by going into the body first and building that resilience, then they can kind of bring the resources they need to the energy. And so there's no
Right,
offense
everything you
taken.
do
Makes sense.
has to connect to the body. If the
body.
client is out of the body, I do not treat that client until the client is back in the body. So that's why I said when they're closing their eyes and remembering things and beep sounds, it's like, where are you going? Like, I need you to stay here. Because during trauma, you were already out of your body.
Mhm.
So when you remember, if you check out again, you're not going to be
Right.
able to heal that.
Yeah.
So, but Lower Parnell has other good resources. So that's why I said it's a mix for me.
This would be a good referral for Matt and Esther, right? And Dan maybe too.
Can Matt do it? Are you women only or?
No, we're co-ed.
Oh, great.
But the residential was.
The residential.
Okay,
Yeah.
that's what, yeah, I remember.
Yeah,
something
because
was-
under the same roof for trauma, because most of my clients are rape victims, I didn't want to make them live together.
Mhm.
But in here, co-ed, we make it
Okay.
work.
And how about concussions? Do you get a lot of people who've had concussions?
Not too many.
TBIs, we get a lot.
That's not as common for us, right? Occasionally, but it's not as common for us. It is more childhood issues, attachment, a lot of attachment stuff, and that's harder work, you know. But sexual abuse is a main
So
common.
Pamela would have been right for this, but she's going back to Florida.
Yeah,
She would have been
Yeah,
perfect. Because we get them stabilized, you know,
Correct.
generally
Right.
45 to
60 days.
90 days, even
Yeah.
sometimes we're lucky, and then they're ready for
that integration.
integration. I didn't know you were that close, so I'm excited to hear that. For some reason, I kept thinking like you were in Santa Monica or Culver City or somewhere like that, but you're
Yeah,
not
Palisades.
too far. And Spiro is wonderful. We
Yes,
love-
1 mile exactly from
One
from our
mile.
location, you know.
He was the former clinical director of Promises. He's doing our EMDR. He works at another place too, so he can't always be here at the staffings, but I will pass on this information. Still, I think we're getting more people with concussions, TBIs. Celeste works with us. She's been with us 10 years. She calls in for the meetings. Unfortunately, she was here on site for 10 years, but she's now in Arkansas, so we don't get to see her, but she still works with the patients through Skypes. And then Mary McGraw from the Betty Ford Center is joining our team to do more family work. We're upping all the family systemic
Oh, that's
work. I
great.
mean, we do all the boutique sessions, private sessions based on their unique diagnosis and characteristics, but we're finding that the families are coming in that are more complex too, more people using in the family, so we're gonna be adding more education, at least monthly. She'll be coming from Palm Springs. She ran the program in Betty Ford for many years.
To be honest, you guys are always my first resource. I don't know if
Thank
you've
you.
noticed it, but often I call and say, okay, but many times clients don't